Good evening, everyone. Welcome back to another episode of Mind Split Cafe. We always appreciate you joining us. As you can tell, we are Mattless again on this episode. He had a prior engagement that he couldn't make. Breaks my heart because Matt always makes these entertaining and fun. But we're going to see what we can do with this episode today. Today we have Tom McCarry, who is a licensed mental health counselor, and he is also the CEO of Zero Overdose. Tom, you want to introduce yourself, give us a little bit of background, and explain what you're doing here on the show and what your mission is?
Sure. First of all, thanks for having us on the show, having me on the show. It's really
Yeah.
exciting to participate, and I got a chance to listen to some of the other episodes. So I'm excited to be here and share this message with your audience and get to have a bit of fun, volley some ideas around with you. My
I love
name's
it.
yeah. So my name's Tom McCarry, and I was working in a federally qualified health center with my co-founder Verna, and what we realized is that there were more and more overdose deaths occurring, and some of these were happening for individuals with known risk factors, right? So we started to look around to see what types of tools were out there that we could introduce to this network of health centers. And what we identified was that there was this just major gap in clinical tools. And so we started to look at other population health approaches for preventable death, like suicide. And where there's tons of research, there's a long-standing body of research and tools and best practices. And what we've started to do is to try to adapt and apply those to overdose prevention. And that really springboarded the development of our overdose safety plan, which models evidence-based suicide prevention safety planning, and a host of other risk screening and methods of improving how health centers and providers can help those at risk for overdose.
So it kind of sounds like you are trying to not only mitigate the overdose, but prevent it from even getting to that point. It sounds like you guys are trying to start at the top versus at the bottom with what Narcan is, just saving someone that is overdosing. It sounds like your mission is to start much higher up there and even prevent them from getting to that point. Am I on the right track there?
Yeah, absolutely. Yeah, Narcan is revolutionary, right? Like it
Oh
saves
yeah,
lives.
absolutely.
It saves lives, and it's a very effective emergency medication. The other sort of best practices that have been out there for some time is medications for opioid use disorder, like buprenorphine, methadone, other Vivitrol or naltrexone.
Naltrexone, naloxone.
Yeah, the number of people who are, first of all, have access to these types of medications is growing over time, but there's a very, very small percentage of people who would benefit from being receiving treatment for substance use issues than the number of people who are at risk for overdose. And so we really can't rely we have to create something which is much more accessible, can be widely adopted, and with the goal of educating and helping engage people in their care in a way which helps support their autonomy to make choices that can reduce their risk for having an overdose.
Okay, yeah. So it sounds like you guys kind of have a complete tool bag of items and different things that someone can utilize to get over that or over addiction or through addiction and completely jump over the overdose part. What other tools do you guys utilize, or what else is included in this?
It's a great question. So the flagship is a safety plan, which is at the end of the day a one-page piece of paper right? It's something that somebody can physically walk out the door with. And these have been shown to reduce incidence of suicide by up to 50% in high-risk individuals. So this is based on evidence-based practices. And so what we do is we train providers, we train healthcare organizations and social service organizations, primary care settings, how to implement this with the people that they serve. So a clinician, a provider, a social worker, lots of different helping professional roles work with an individual to help them identify their risk factors, identify some of the things which put them at risk, increased risk for overdose, help that individual identify things that they're already doing or would be willing to do that can effectively reduce some of those very individualized risk factors that they engage in, whether it's how they use, where they use, how much they use, and coming up with harm reduction strategies. And then pairing that together with supports, other things that they can do to help keep themselves well, and identifying their care team, people that they're engaged in care with. So in a way, it's a structured method for guiding the conversation in a standardized way around risk factors, harm reduction strategies, and ultimately trying to change the way risk of overdose is even thought about through the terms of somebody receiving care, that this is not being done in a policing way. This is not in a way that this is going to negatively impact your care. But this is the genuine desire for providers that you stay alive, and acknowledging that we're in an overdose a crisis at this time, right? And that having straightforward, honest, and open dialogue around these types of things can increase engagement and rapport with between whatever type of the provider it is and the person that they're working with. That this is something that should be talked about within the health setting.
Yeah, I absolutely agree with that 100%. I think that it's something that's not talked about enough. It's stigmatized. I think what you guys are doing is normalizing it, and that's something that's long overdue. And I'm not sure if I understood this properly, but it sounds like you guys try to get into freestanding ERs or emergency rooms or primary care doctors to get these quote unquote tool bags to the providers to give to their patients if they see them red flags of substance abuse, or even if they had the overdose, instead of just treating with an overdose and sending them home. Now they have a toolkit from Zero Overdose that allows them relapse prevention and things of that nature, correct?
Exactly, right. Yeah, and I think an important piece of it is that it's collaborative, right? This isn't just something that you say, hey, this is something that you could benefit from, and that's sort of the end of the conversation. The collaborative nature of it is important, that this is the dialogue between the provider and the client in helping to create this together, and continue to integrate that in their care in some way.
Yeah, so absolutely, the ongoing care is definitely going to be something for relapse prevention, or even just obtaining recovery in itself is an ongoing process.
Right.
Now, how do you guys go about getting into the doctor's offices? I mean, are doctors open to this? Are hospitals open to this? Is there any resistance? What's going on with this?
It's a great question. You know, we're a small organization, right? And so this is it's myself, a co-founder. We have a part-time director of operations. We bring on other people on an as needed basis, but we're a very small operation, and we want this to be everywhere. We want to get this tool out as wide as possible. And so there's a lot of interest in it. There is a lot of interest in it. You know, when we do presentations at conferences, we try to network with some large associations and to present and to promote that within their the organizations that they work with. But it's something that is still the discrepancy between the need and the access and adoption is very wide. It constantly
The
feels
spread's
like
still
it's
there.
yeah,
I can
unfortunately.
understand.
Yeah.
So I'm just blown away with this entire project that you guys are putting together. Because I mean, I've seen, you know, like relapse prevention groups. I've seen people that give away Narcan and clean needles and harm
Mhm.
reduction stuff. But you guys are the entire package wrapped into one, and it sounds like you guys should just be out there everywhere. Um,
Thank you.
and I find it phenomenal because you can help someone that's in active addiction, in recovery,
Mhm.
just getting started. You have
Right.
a tool for every part of the addiction process, the Jelinek curve. You can touch everyone on that curve. I
Yeah.
think it's phenomenal.
Yeah, I think you mentioned something there that stuck out to me is that, you know, the path to recovery is not always straight, right? And so one of the challenging elements to overdose prevention is that when people are in early sobriety, if people have had any period of abstinence from opiates, this is something which actually increases their risk for overdose, right? And so how to
Absolutely.
include that type of conversation where so much of treatment has traditionally been abstinence based, where it's relapse prevention and, you know, everything is really focused around maintaining that abstinence. And sometimes a blind spot to that is, how do we acknowledge that resuming use or slips, relapses, whatever we want to call it, occur frequently. And so how do we talk with people honestly and openly about risk for overdose in a way which doesn't, it's not giving permission. It's not saying, I don't think that you can do this. I don't think that, I know that you're not going to get this. You're going to have slip, you're going to fall, you know, and just kind of just normalizing the conversation that isn't part of everybody's experience. But in the event that you do resume use, there are things that you should know that to help keep yourself alive.
Yeah, absolutely. I've read a lot of statistics, and like I told you off camera, I'm actually working to get my licensing in different mental health clinic or different mental health licensing. So I've learned a lot about that, and it seems that most people do overdose when they have that short period of time of abstinence because their
Mhm.
tolerance has gone down, and they
Yeah.
go right back to that same dosage that they were doing prior to getting clean. So it's, I mean, that's you hit the nail right on the head with that one.
Right. Right. And now with the wide prevalence of fentanyl, very high potency opiate, synthetic opiate being mixed in with all types of substances, right? People who,
Everything. I mean,
it's
it's
in
being
everything.
mixed in everything.
There's really, it in some ways, it helps to simplify the conversation, right? Because I don't have to be a detective. I don't have to figure out, you know, is this person using opiates? You know, if they're talking with me about any type of substance use, they occasionally, you know, use cocaine when they're out at bars. All right, well, you know what? I don't have to worry about making it. It changes the way that we think about it, right? So much of clinical work is starting with a diagnosis, right? Does this person meet the criteria for having a cocaine use disorder? Like, in a way, I don't really care, right? It's not the point. Like, I don't care if
They
there's a diagnosis. This person
still
uses
might need help.
cocaine. Some of the time, you know, we have to start first with safety, the diagnosis can be important, right? But it's not where we need to start. We need to start with keeping people alive, having straightforward and honest conversations around risk for overdose.
Yeah, and I'm going to say this right now, like I have so many questions and we can make this a 4-hour episode, so we may
Let's
have to
do it.
chop it up and get you in a couple different episodes. But one of these burning questions in my head, and it's not a question from me, but I know there are a lot of people out there
Yeah.
that would say, are you just enabling people now? You're just making it okay for them to use because now they have a way to stay alive and fall back, which I don't believe that is the case, but there
Hmm.
is arguments out there. I mean, that's one of the most notable public discourses of Narcan is you're enabling them, or
Hmm.
harm reduction. You're allowing them to do it and you're making it easier.
Yeah.
Um, what's your thoughts on that? And can you elaborate for me?
Sure, sure. I think we're going to see if this analogy fits the bill. It's what first came to my mind, and I like it. We'll see if it really hits it. If not, we'll try a different angle. But what I think of oftentimes is, well, thinking about addiction through the lens of a chronic illness, right? The person who has diabetes goes to their endocrinologist, and the endocrinologist is like, hey, listen, I've had this conversation with you so many times. I've told you that donuts are bad. You keep coming back and your A1C is still high. I'm sorry. I told you last time, that's it. If you come back and your blood sugar is still dirty, I'm not going to prescribe you this insulin any longer, right? And you came back today and you gave me dirty blood again. It sounds bonkers, right? Like that never happens.
But they
I'm
do it with
purposely saying
athletes.
dirty, right? Because that's not a medical term. But when we're thinking about substance use and addiction, people say, oh, there's dirty urine. 3 strikes, you're out. This just doesn't, it's not how medicine works. It's not how illness works. And so language is important. Changing how we think about and even approach it and purposefully saying, your urine drug screen was positive for cocaine, right? You didn't have a dirty piss or whatever, right? Like, and I correct patients when they say it because it's just so ingrained as well, right? It's not just the providers, the patients and consumers. We've been taught this is language that we've been learned. So I don't know if that answered the question, but I wanted to use that analogy. The question was, what do we say to people who are like, well, why do we keep doing this? Why
Are you enabling them, or
are
why are
you
you giving
enabling
them the
people?
ability to do it?
Yeah, well, let's just stop giving insulin because it just enables people to eat donuts when they have diabetes, right? So we don't think of it. It was like, I could get canceled if somebody took that out of context, right? Like,
Yep.
that's so shameful to have to say something like that. But it's just, it's different for substance use. And so how do we normalize substance use? And at the end of the day, I think stories of recovery are really important as well, right? The person who has struggled over and over again and then achieves recovery and come back and say, hey, listen, I'm so sorry that you had to deal with me. I was a real jerk, but thanks for keeping me alive because now I'm doing these really cool things. And I wouldn't be, and so that's really important, is that message of recovery and hope, because it's real. Right. And I've heard the Surgeon General, this is Dr. Murthy. Dr. Murthy is, I love Dr. Murthy. And one of the drums that he beats is that, treatment is effective and recovery is possible, and so what I would add to that is, if the person stays alive, right? So treatment's effective, recovery is possible, but only if people stay alive. And that's, where that's the baseline that we come from, and the lens that we look at things is that keeping that importance, keeping that safety up front, right? And that everything else can fall into place, may not fall into place. But our role, if we're in any type of helping field, we need to be thinking about what we can do to help keep people alive.
Yeah, I agree, and I like the analogy, because I got an analogy for you too. But I want to say this first. It's you mentioned diabetics needing insulin to survive, to function, to go about their daily life. But there's also addicts who are on MATs, medication assisted treatment. So whether it be Suboxone or
Yeah,
methadone, and
yeah,
they need the medication to survive and function.
sure.
Yet they're looked at differently. They're looked at like,
Hmm.
you're an addict, that's why you need this.
Hmm.
But it's okay for a diabetic just to get insulin every day to
Hmm.
survive. Nothing's
Hmm.
wrong with that. They didn't choose to be diabetic. They didn't choose to be an addict. So
Hmm.
there's definitely a double standard, and I
Hmm.
think that needs to be addressed more often than not.
Absolutely.
Um, and
Absolutely.
this analogy that I'm going to say, I actually said it in one of our other episodes because we had a substance abuse episode.
Great.
But the thing that drives me crazy about the um, not mental health, but substance abuse part of the mental health field is you go to counselors or a treatment center, whether it be inpatient or intensive outpatient, and they may not say this specifically, but a cucumber can be turned into a pickle,
Yep.
but a pickle can never be turned back into a cucumber. It's just physically impossible. So
Yep.
these clinicians, these counselors, these doctors are saying, you're no longer a cucumber, you're a pickle. You're going to be
Right.
different the rest of your life. You're going to
Right.
struggle the rest of your life. You're never going to be the same. And
Right.
I think that leaves the door open for relapse before they even get started, or for failure before they even get started.
Sure. Sure. Yeah, I don't drink. I used to drink alcohol. Now I don't drink alcohol. And so for me, the pickle analogy, I didn't interpret it in a negative way, right? But I think it has to be careful, right? You can't have one. Because again, it's very individual, right? Like
Yeah.
what gets what gets one person sober is going to get the other person high, right? For me, the pickle analogy, I was kind of like, well, this was part of acceptance. I was like, you know what? To me, what I thought is like, all right, I'm I'm never going to be able to drink alcohol again safely, right? Like I can drink alcohol, but this
It's going to turn
illusion,
out bad.
yeah, this illusion that I'm someday going to be able to drink alcohol in a safe way, I have, I have to I can't hold on to that because that's not going to help me. So for me, the pickle analogy, it kind of like was helpful. But you have to be conscious, right? Like you have to be aware of the individuals, and there has to be there's many pathways, and not everything's going to resonate with everyone else. And so I think you're right in that the traditional addiction treatment model is very one size fits all, and
Yes.
abstinence directed, right? And more we're seeing that change. And but I think one of the other challenges is that many people working in the field of addiction are in recovery themselves. So
Absolutely. It's like 80 to 90% of the people are.
yeah, and it's helpful in many circumstances, but it can
Yeah.
also blindside. And we work with that quite a bit when we're working with addiction programs. You would think, oh, well, this is a great fit. Safety planning is a great fit for addiction programs, and it is, but you're also working with people. And so sometimes challenging, helping them to see their fear and stigma around substance use. So for some people, talking about harm reduction, talking about it is challenging their own sort of view of what they need to do to keep themselves alive. And so how do we help, how to make sure that as a helper, you can have your own pathway, but understand that that's maybe not is not going to work for everybody. You have to maintain that flexibility.
And that's kind of what I wanted to touch on as well. And I think that you guys are doing a really good job just from the brief research and discussions with you. Is not every recovery program is going to work for everyone. Like the 12 steps, NA,
Mm-hmm.
AA, it's not all going to work for everyone. There's different programs out there. If one doesn't work for you, don't give up. Go to
Mm-hmm.
another one, or take bits and pieces of each recovery program and make your own. And
Yep.
I will tell you that I had an issue with substance abuse at one point, and I was able to take different pieces from other recovery programs, made it my own, and we'll
Mm-hmm.
call it Mind Split because this is part of my
Sure.
therapy. I love doing it.
Awesome.
Um, but it worked for me. You know, they
Mm-hmm.
said, you're not going to be able to do it because you're not doing the 12 steps.
Right.
And I did it. And I showed
Mm-hmm.
them that I could do it my way because not everything resonates the same with everyone.
So
And
important.
and I love what you guys are doing because you tailor it to each person, and not one shoe is going to fit the same person. And I love that. I think you guys are should be the gold standard of recovery, and I believe that wholeheartedly.
Thank you very much.
I
Thank
think
you.
that that's awesome. And also, I just want to say that the pickle thing, I see how it could be two-sided and be a good thing and kind of a negative thing. But
Sure.
in my instance, it became somewhat negative,
Yeah.
not just for myself in my head, but they told my wife this, like,
Uh-huh.
he's going to struggle the rest of his life. He's going to be an addict the rest of his life. So
Right.
when I got home from treatment and I started doing something different, like it was I was working from home, or like I didn't have to really go to work. I could work from my computer. So I started
Yeah.
walking around the condo complex that we lived in,
Yeah.
and she called me and she's like, "What are you doing?" It's like, I'm walking around the complex, and she's like, "That's weird. You've never done that before. You must be doing something with substances now." So with them telling her that, everything just
Uh,
led back to that's what he's doing now.
uh-huh.
So I see how it's a good thing, and I can see how it can negatively affect things too.
Yeah.
So it's just tailoring everyone's recovery to themselves, and their support system, I think, is the main thing.
Mm-hmm. Mm-hmm. That's actually something that we are looking to bridge into, is providing psychoeducation for family members, for collaterals, for partners, that don't that want to be able to help and don't necessarily understand and what risk factors are for overdose, how they can help support their loved ones. And so that's something that we're looking into doing. We're applying for a grant that would help us make a zine, like an overdose safety planning zine that
That is
provide
awesome.
yeah, it's gonna be fun.
Kind of
I
like
have
an Al-Anon, but on the other side of it.
Yeah, exactly. Yeah, yeah. And well, it's gonna talk about what are risk factors, just kind of demystifying and breaking myths about overdose. So it's something that could be used for either an individual who is at risk, but it can also just be educational for somebody who wants to understand it more.
That's awesome. I love it. And I have one last burning question. You being a mental health clinician, there
Yes.
are various modalities out there. You have CBT, DBT, you have
Yeah.
motivational interviewing.
Yep.
Which one do you think works best? And I know this is going to be hard to answer because I just said it myself. You got to tailor it to each person. Everyone's going to be different. But for substance abuse as a whole, what modality do you think is the most effective?
This actually is, for me, I feel like it's an easy answer. Motivational interviewing is like the I don't have a good analogy for it, but it's like the easy pass. It fits on everything because it's just
Yeah,
it's the way of interacting with someone. So it's also not mutually exclusive, right? So like I can embody motivational interviewing and use other interventions as well. But motivational interviewing is a way of it's not, maybe not going to sound right, but it's very, I was going to say disarming, but it's helps to reduce people's resistance, because it's so strength-based, compassionate, and you're wanting to, and collaborative, which all of these things
That's huge.
are huge overlap with the principles of harm reduction, and also evidence-based ways of helping people through the stages of change, right? And so some of the skills in motivational interviewing, they call it, there's lots of not acronyms, right? So there's ORS, open-ended questions, reflective affirmations, reflective listening, and summarization, right? And so this is just a great way to that we embed this in our training throughout it, because no matter if somebody's had tons of training in motivational interviewing, or this is something that's kind of a new concept, what I love about it is that you can, as soon as we shut off the training, the next person that they interact with, they can start using these skills immediately, and it's like a black belt sort of jujitsu kind of thing. I don't know. That's a weird way to put it, but it totally works.
Yeah, I mean, it embodies pretty much all the other modalities into one, I feel like, at least. And the one thing that I find is very controversial, not with motivational therapy, motivational interviewing, but is exposure therapy. I find exposure therapy crazy. Like that's weird to me. I think that's a gray line, but it may work for some.
Individual results may vary.
Yeah, absolutely.
But motivational
Tom,
interviewing is great,
I love it.
so yeah, maybe we can put a tag or something in here for some information.
Yeah,
on
well,
that.
I was gonna say, right here at the bottom of the screen, we're gonna put your information, your
Awesome.
website, your phone number, so anyone can get a hold of you if they have any questions, concerns, or if there's even a provider that has been on the show or listens to the show, wants to speak with you, they can reach out. We'll put you on our resources page. Um, I think you should come back for another episode because, like I said, we can go all day long with substance abuse and overdose and what you guys are doing. I think it's phenomenal. Any way that Mind Split Cafe and 610 Marketing can help, let us know. We'll be glad to help out any way we can. To our listeners, if you guys want any advice, more information from Tom and Zero Overdose, the contact information will be on our resources page and at the bottom of this show. So reach out. And Tom, what is, give our listeners one solid piece of advice to follow in recovery, if they're thinking about recovery, in recovery, or an active addiction. Just a solid piece of advice for them. What you got?
Wow. All right. Well, that's all right. A solid piece of advice at the end is, well, hope. I just want to convey hope, right? Like, recovery is possible. Here, I'll steal the words from our great Surgeon General. Treatment's effective, recovery is possible, and there are things there, as long as you stay alive, right?
Yeah.
And so whatever you can do to be aware, look into, lean into aspects of your recovery or your use, those who are around you, things that you can do to decrease those risks, whether it's carrying, getting trained in how to use Narcan and carrying it, access to fentanyl test strips, not using alone, using with other, making sure that you're not by yourself when you're using less over a longer period. You asked me for one, I'm going to give you like a laundry list.
No, bring it on, man. We need it. There are so many people that need to hear this. Bring it on.
Learn, educate, education is key, right? I'm just a person who's taken information, from other places and kind of putting them together. But it's helping to get the information so that you can make more informed choices.
That's smart. That's beautiful. I think that is solid as can be. I have one last thing that I want to say, and it may be morbid, but it kind of goes along the lines of what you're saying, is addicts are going to quit one way or another, whether it's on their own volition or they're institutionalized or they die. One way or another, they're going to quit their substance. Let's keep them alive and let's keep them going with Zero Overdose. I think you guys are the ladder of the choice, and we need to push yours a little bit more.
Thanks so much for having me on the show. I look forward to
Yes.
coming back.
Tom, I appreciate it. Zero Overdose, I appreciate it. We're going to put all your guys' information on our resources page. If the listeners, if you have any questions for Tom, submit them through our website. We'll get Tom to answer them on another episode. Other than that, we appreciate you guys, and we will see you next Wednesday. Good night, everyone.